So multiple myeloma treatment used to be quite simple, and I'm talking about 30 years ago. This is when we had three drugs and it didn't work very well. So we did what we could do. What has changed and made the treatment exciting but also complicated is that we have 14 new drugs in last 15 years. So almost we have one new drug a year. In last 12 months, we had three new drugs approved for myeloma, including a CAR T cell, a cellular therapy. So first, the element of complexity is because we have so many good choices, and these are very effective drugs. Second thing is that we are beginning to understand the myeloma better, biologically, genomically. So that also helps us understand which patient would receive what. And we're understanding better the prognostic factors in patients, high-risk myeloma, standard risk myeloma, etc. And so we are able to select appropriate treatment based on some of these features. And the last element that makes the treatment complex is that combinations work, of course, better than individual agents. And there are many, many studies done which says that the 3-drug combination is better than 2. And now we are beginning to have 4-drug combination, which works better than 2 and 3. And what are those 3 or 4 drug combinations? It includes a proteasome inhibitor, and there are 3 of them. It includes an immunomodulator, and there are 3 of them. And then it includes monoclonal antibody, and we have 3 monoclonal antibody, 2 belonging to the same target, CD38. So combining them together gives 100% response rate and almost 45 to 50% complete response rate. And so now when patients relapse, we would then utilize another 3 drug combinations. And you can see that with 13, 14 drugs available, there are permutations and combinations that one can utilize. And selecting them in the right sequence, encompassing various patient features, disease features, etc., brings about the complexity. And also at the same time, it also makes responses very meaningful in the subsequent line of treatment. So I think treatment selection in myeloma is dependent on various features. Some are very patient-specific standard features. For example, frailty of the patient, age, status, disabilities, etc. Then we look at disease-related morbidity, relapse disease, refractory disease, renal failure, bone disease, etc. And then risk assessment, high risk, low risk, ISS, cytogenetics, and the patient's lifestyle. But the most important feature that we consider while including everything else in selecting some of these new agents is patient's treatment history. What did patients get last and how well did patient respond? And so based on that, one can pick the agents with less neurotoxicity, agents with less blood counts problem, etc. And so the selection partly depends on this. The second component here in these newly approved agents is also the efficacy. How well these treatments work. Do I get 80% response rate, 30% or less? And I think that is what is also utilized. And then the toxicity of this drug. If a particular drug has higher toxicity, then we would lean towards lesser toxicity. And so the risk benefit being the response rate, risk being the toxicity, we have to balance. We try to get highest benefit with as little as possible toxicity. And that goes into determining some of these. So CAR T cells has brought about great excitement, partly because of the fact that it gives close to 80+% responses at the target dose. However, CRS, cytokine release syndrome, is a toxicity that we have to be aware of. And we have to try and mitigate it and also keep in mind patients' various features, including performance status and other things. Now, the question you asked is, how does this choosing new agents and upfront autologous transplant come about? So currently, all these new agents are approved for later line of treatment, 3rd, 4th, and 5th line and beyond. However, because, for example, CAR T is so very effective, we are already investigating it in earlier line, 1st and 2nd line. There are planned studies to compare it with autologous transplant to see CAR T gives similar depth of response as transplant does. So currently, I think transplant has its place, but I think it's going to be soon challenged by appropriate utilization of CAR T cells in the right patients at an earlier time point. So I think one should watch out now for this comparison between CAR T versus transplant and see which patients would benefit from which of these interventions. After saying that, I think transplant still provides benefit. It still remains an important treatment to be considered for younger newly diagnosed patients.